of my knowledge, but also the understanding regarding this such an important subject, not only for nursing, but for all the future healthcare professionals and the actual ones in this field. So for me, is a real and true pleasure to be with all of you again and to share a few thoughts around this topic. So to start, I would like to share a presentation that will guide us a little bit through this process. I believe you can see my screen now.
Yes, it's visible.
And perfect, that's brilliant. And based on Robia said, today I have the privilege to start this series of seminars with a very basic one, but I think very important because it will give us the foundations about how do we use assessment in terms of the progress, not only for students, but for healthcare professionals, and also to open a little bit the idea that the assessment can be not only for the individual, but also for a system, for organization, for institution. So when we think about simulation, simulation is a very powerful methodology. And today we are going to have just a preview about how powerful it is and how can we use it, and especially face it with the and contrast with the standards of in Excel, which I believe they are very important and very useful when we are not only learning about simulation, but also when we apply simulation in a daily basis. So I would like to start to declare some conflicts of interest that Roby already said. I don't believe it's conflict of interest, but everyone here has different affiliations and work in different contexts. So as Roby explained, I have a clinical site. I do have also educational experience and work, and also in terms of society. Now I'm one of the executive board members for the Society in Simulation in Europe. So everything that I'm going to share with you is the cumulative learning processes that I have in these different contexts. And for me, it's a pleasure to share all this content with you, not as a conflict of interest, but as an opportunity to share the information with others that might feel it's important and contribute as well for the community. In terms of rules for this seminar, please feel free to interrupt as much as you would like. Bring your ideas. If you have any questions, don't hesitate to raise your hand or open your mic and do your questions. We will reserve also some time at the very end for you to do some questions, but open your mind and feel that this is a process of sharing knowledge, so you can also tell us your experience, your needs, your considerations about the topics we are developing, and any idea that you would like to transmit. Just be more than welcome to do it. Photos you can use and you can take as much as you would like. This information is for all the community, so I do believe that it needs to belong to everyone. So if you feel that some slides are interesting and you would like to take a picture, just feel more than welcome to do it and use it for future reference if you would like to. So now we're going to start with a very, very broad concept, which is clinical simulation, and with a very broad question as well, which is, what's the goal of clinical simulation? When we think about clinical simulation, we think that it's used and this methodology is implemented for the clinical safety, for quality of care, and for well-being. I believe that clinical simulation is applied and helps in these three main components. Clinical safety and quality of care is something that we already know, and we might intend to relate it with the clinical side. But the well-being is, for me, one of the most relevant ones, and that sometimes we don't talk about it. But when we think about these three components, we need to understand that this applies not only for the students and healthcare professionals, but also to the patients as well. So when we are educating through clinical simulation, when we are practicing and using this methodology, we are generating different opportunities to transform the way we see the healthcare environment and system. So simulation can be one of many, many methodologies that help us to improve these three components, but we need to always make sure that every single thing that I produce, that I design, that I apply in clinical simulation, it will have any impact in one of these three components towards the patients, the students, or the healthcare professionals. So this always gives us an idea and an answer when we have any questions about if what we're doing in this field is impactful and will be impactful not only for us as educators, but also for the target population that we would like to apply to. And what do we need to know about our participants when we would like to apply simulation as an assessment strategy? And I would open this question not only for the assessment, but for any kind of simulation-based education process we would like to do. We need to personalize and we need to understand that every single simulation scenario or implementation process is unique. And being unique, it means that we are delivering it for a group of people that has different intellectual needs, personal needs, professional needs, and educative needs. So as facilitators, we need to make sure that we comprehend and we are aware of these needs. And sometimes it's very complicated for us to make sure that we have this capability to detect everything. So with this presentation, I will give you just 3 small tips about what we need to know about our participants before thinking about applying simulation as an assessment methodology or as an educative methodology. So I do believe that there are 3 fundamental characteristics from the participants that we always need to know. One of them, and the very first one, is the clinical competences. We need to know how competent are they about the subject that we would like to work with them. We need to understand the level also of experience, not regarding the competence that we are training, but in general as a professional, as a student. What's the level of experience of this professional? And combining these two, the clinical competences and the professional experience, then we can start designing an approach that is more or less related to the sim zones. So now it might be a little bit confusing what I'm saying, but the next few slides will give you a little bit of an idea about what do we actually need to know about our participants to make sure that we are generating impactful actions towards their educational improvement. So in terms of clinical competences, what I would like to show you here and represent is the escalating process of knowledge that the majority of people know and recognize, which is given from the Miles pyramid. Miles pyramid gives us this idea and this structure that we have some steps that we need to take to make sure that we can get to the top of the learning process where we are capable to do, to reproduce something in a real environment. And as you must know, universities and the majority of the learning process are based on this pyramid. We start to give theoretical inputs, information, to make sure that our participants and our students, they know about the topic we would like to work with them. After this, we start to give some points about the applicability of this knowledge to the practice. So we start with clinical cases, we start to see and to share with them how can it be applied in a theoretical way. So we start to show them the know-how of the topic that we are developing and learning with them. And the majority of the cases is when we do this know-how, the theoretical practical part of the learning process, we tend to jump directly to the DUS. We tend to jump directly to the clinical field and practice this theoretical information that we gain and retain to real patients. And this we saw many, many years ago that might be dangerous, not only for the patient and their families, but also for the learning process of the participants and the students. So the Miles pyramids gave us this information, and for many, many years, they told that the learning path should include one step that sometimes we are not conscious about it or we forget to apply it. And we understood that probably simulation could be the vector, could be the vehicle that could help us to generate and to implement this step that sometimes is forgotten, which is the shows. We need to understand that all of our students, before being in the clinical field, before doing a practice on a theory or um, 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 a technical or social cognitive skill that they've been practicing and learning about, they should be able to practice in a safe environment before doing it in a real world context of clinical on the clinical side. So this is the reason why simulation, we believe, could be a facilitator in the Myers pyramid when we think about the transition from the know-how to the does. And when we think about this, we need to understand, and I'll go back again to this pyramid, that simulation is centered on this step. So we can only apply simulation if we had the possibility to practice with our students the two other steps before, the know-how and the knows. No one should be doing simulation if they don't have the possibility to develop knowledge, theoretical knowledge, and around the know-how and the know of the topic that we are developing and implementing with them. So this is a very interesting point, because sometimes we tend to push our students to a simulation scenario or to some simulation programs without exposing them before this strategy and methodology with theoretical information about the topics that they are working on. And the second point is actually the professional experience. We need to know that for the same topic that we are developing or they would like to offer to our participants, some of them, they probably have different levels of professional experience. And sometimes we need to adjust the content that we are going to deliver to make sure that we meet the expectations that they have in a professional level, but also meet the needs of their learning process as professionals or students. It's totally different if I going to do a simulation scenario about, for example, placing an IV line if for a nurse that has 20 years of experience, when I'm doing the same topic to a nurse or a student that is on their second year of the undergraduation process. So when we think about a topic or something that we would like to work with our students and participants, we need to also make sure that we know what's the professional experience of the audience and the participants of this simulation scenario to make sure that we can align not only their expectations, but also the learning outcomes that we are proposing for the scenario. And with the combination of both of them, this is a representation of what we can do based on the learning process that we've done in the University of Barcelona. And as you can see, this is a Myers pyramid, and it's in Spanish. I do apologize, but it's not translated already to English, but I will tell you what it says. It's the inverted phase of the Myers pyramid, as you can see, a step process where we start with the know. This is the very beginning. We need to make sure that we find strategies that our students know the theory, and then we give a step further to the know-how. We can do a few processes where we include case studies. We can work with them the applicability of this content to the clinical side, but in a theoretical way. And then when we had the possibility to build these two steps and also to evaluate the level of knowledge and capability they have, when we do assess and see that they are capable to do it, we can offer them the opportunity to show it, to show it, and they can show it to show it through clinical simulation, for example. So when they start in the clinical simulation process, they need to start with abilities. They need to start with small and non-complex scenarios where they can see the applicability in a safe environment. And then when they know the technical or non-technical skill in a small scale, we open a little bit the complexity of the scenarios where they can and they do take decisions towards the topic that they're doing. And then when this decision-making process is consolidated, we can step a little bit further and we can open and increase the complexity of the scenarios where we can imply team dynamics and bring this in a dynamic process where it's not only about the intervention that we are working with the student, but also we consider the normal process of healthcare that potentially a patient would have and their family would have. And then when we finish this and we had the possibility to assess the capabilities and competences of our students, then we can do this step further and then we can go straight to the do. We can invite them to go to the clinical practice and train directly with real patients to see and for them to compare the differences between what was the learning and the safe environment of learning towards the other part of the safe environment, which is the practice in the clinical field, but with a different responsibility towards the patients and their families. And during all this process between the know and the show, they should have the possibility to do self-demonstration with self-feedback about what they do. It's the self-learning process. It's very important for them because this is something extra that they can do, and they can we can stimulate students to do it through the different phases of the Myers pyramid. And something that is circled around all this process is the clinical debriefing or educational debriefing, which is fundamental to give feedback for our students through the briefing, for example, about the way they are evaluating on this process of escalation of learning and how can they improve their actual capabilities towards a level of competence on the clinical side that they can feel competent about the skills that we are training with them. So I will give you oh, sorry, Rubia. Yeah, please.
Yeah, actually, can you the participants are requesting that can you mention this labeling in English words such that they could note it down?
Course.
Yeah, the same part. Yeah.
I will do both things. I will do two things. I will do a demonstration of an example, and when I do the demonstration of the example, I'll say the translation of this word.
And so, Pedro, your sound is coming from far away. It means I think.
Oh, yes. Sorry. Can you? Is it improving now?
Yes, it's
better like this.
Better.
Perfect, brilliant. Yeah. So I'm a little bit closer to the mic.
Yeah.
So when we think about the learning process, let's think about something simple in the clinical field. Let's think that we would like to develop a learning strategy about IV placement, what we said before. So we are doing a practice and we are starting to develop a learning path for our students about how to place an IV line. So to start this path, I need to start with the know, sabe, know. They need to know all the theory behind the physiology, the anatomy, the importance and why do we apply IV lines, how they made of, how do we use it for, the different characteristics of the IVs, the treatments that we use, with anatomically, where can we place these IV lines, how do we use them, for what we do that we do use them. So this is called the sabe, know. And when they have this theory constructs, we give a step and we start to work with them the theoretical, practical part of this knowledge, which is knowing all this information, we're going to start to apply it to the clinical field. We are starting to talk with them during classes about some case scenarios and some clinical cases about where can we apply the IVs lines, how do we use them, for the reason why, for specific pathologies, for specific patients, and probably the pros and cons of some ways to apply and use the IVs. And when we had the possibility to do the know-how, sabe cómo, know-how, when we finish this circle, we need to assess our students to make sure that they met the the educative and theoretical objectives that we proposed for them. When we know that they could do and they know about all we've developed about IV lines, we can offer them the possibility to do a step further to the demuestra, to show. And how can they show? They can show that what they know through clinical simulation. And clinical simulation is one of many methodologies that we can use in this phase. So we can use simulation to train the ability, habilidades, the ability of only putting the IV line, to get the IV and place it in a vein, and practice this as many times in a mannequin to make sure that they know the process of selecting the vein, disinfecting, selecting the correct material, pick the material, place the IV line in the vein, see the flush, and finish and put the dressing on this IV line. And this is the pure ability, is to know how to place it. When we access and we know that they are capable to do this, we go a little bit further. And now we're going to give a little bit of cognitive complexity on this process. We're going to train with them with simulation once again, and now they need to start to do some decision making. They need to see the arm of the patient. They need to decide if they want to put a 20G, a 18G, or a 22G, not only because of the arm of the patient and the veins and the anatomy, but because of the fluids that we would like to administer, the period of time that we're going to use that IV line, the zone that we are going to put it in the patient's body, and we're gonna start to give them information about the patient for them to take a decision. For example, we can say that the patient that they will attend, this is a patient that has a mastectomy, and they need to decide in which arm they would like to place the IV. So they need to start to toma decisiones, to do decision making. It's the decision-making process. And we also assess their capability of that. When we assess this capability, we can go up to a team dynamic with a complex system. Dinámicas de equipo en la complejidad de sistema. Team dynamic in a complex system. So it's not only about the patient, the pathology, and the treatment I want to do, is about how to communicate the patient about what we're going to do. Probably is to face the family and explain also to them what we are about to do. How do we react, and how do we give an answer to any kind of complication that might appear to this process? How can we educate the patient about the process of putting an IV and taking care of their IV when placed? So it's the step further that we do to increase the complexity that goes a little bit closer to the real world. So we are doing small steps to make sure that they are step by step closer to what they're going to face on the real world, on the clinical side. Hace, do. To do in a real patient, in a real clinical site, doing the practice. And when they do this, all this cycle, the students can do autoentrenamiento con feedback automático. Self-training with automatic feedback. They can do themselves. They can practice everything that we do during classes or during clinical simulation scenarios, because it's important. It's the same when you study for an exam. It's important that the students have the capability to go home or to come in another day on their spare time, and they practice once again everything that we've done through the different steps of this pyramid. And when we do this, everything needs to be covered by what? Debriefing. Clinical or educative debriefing. as educators, we need to make sure that we give feedback to our students, that we listen to our students' needs, and that we adapt as much as necessary this process according to what we assess during the different phases, but also what they say to us about what are their real needs through this learning process, learning path. I'm not sure if this was clear for you. Is the example good for you?
Yeah.
Yeah?
Yeah, it's clear.
Brilliant. So when we think about how can we use clinical simulation, sometimes in our minds, we only think about this, about technical skills. How about to placing an IV line? How to intubate a patient? How to take care of a wound? And this is very technical. It's skills training. And sometimes we tend to mix the skills training with simulation, which is sometimes different. Skills training is a process where we train a specific task and procedure. When we talk about simulation, we do a step further when we want to give a context to everything that we do with this skill training process, where the judgment, the clinical judgment, and the decision-making process is always present. And that's because sometimes we don't do only technical skills, we also talk about the social cognitive skills. And when we need to take about a decision about putting an IV line or anything, any other process, we are using also some social cognitive skills that we don't know about it in an active way. We do it in a passive way. For example, when we need to communicate with our patients and their family, when we need to take a decision about which way I'm going to communicate, or to take a decision or prioritize something, to know the situational, or to be aware about the situation I'm facing, the next points, and to preview what's going to happen with this patient or with their family. How can I lead the situations? How do I work as in my team, and what's my role in the team and in the scenario I'm practicing? So when we think about simulation, it's much more than only just a technical skill. We cross this technical skill with the social cognitive skills that make us more capable to respond to real life situations in the clinical field. And when we think about, and when we say about social cognitive skills, it's a term that we usually use for non-technical skills or soft skills. But these two terms, soft skills and non-technical skills, we see that they are getting a little bit not used. Why? Because communication, we can have techniques to apply communication. For example, SBAR is a technique about how we communicate and pass information between healthcare professionals. So this means that in this case, communication can be a technical skill as well, because there's a technique behind it. So it doesn't make sense to say that it's a non-technical skill. But another example is, we cannot say that all of the skills that is in your screen, they are soft. They are very strong, and sometimes stronger than the technical skill per se. So they have a different impact, and they are very important in the process and the relation that we have with patients and their families. So they're not that soft. So that's why we think that nowadays these skills are social cognitive, in the way that I apply it to myself and towards the others that are in the same context where I'm working with. So it's very important for us to also consider about the skills when we are assessing, but also when we are teaching with our students in the different steps of the learning path. And this is very important. This is how we need to understand how our students learn. Our students, they evolve in these three main steps. They start with the perception phase. What that means? It means that they see things about the patient, but they cannot correlate about what's going on with the patient. They can see a patient that has fever. They can see that the patient has a low blood pressure. They can see that the patient is sweating. They can see that the patient the urine debit is getting low and low and low, but they just see these points. They cannot cross this information and start to do the second phase, which is the comprehension, is when they to start linking all of this. So if a patient has a fever, it is sweating, the blood pressure is a little bit low, it's tachycardic, the urine output is low, might this patient be in inflammatory or infection process? This is the comprehension phase, is when they start to sum all of this information to generate a possible cause or for the individual events that they can detect. And then when they are capable to develop this phase of comprehension, they start to do the projection, which is, oh, if I have a patient that has this condition and is with an infection, probably I need to start to project to put
Pedro, we are
this
not
to
able
start.
to see your slide. Could you
Oh,
reshare your slide?
yep. Can you see it? The projection?
No, no. Um,
I think someone
Can we
else
go
has
back?
started screen sharing. That is
yes,
why we
yes.
are unable to see.
Yeah.
Okay, I will stop sharing
Yeah.
and I
Again,
will go
you
to
can
share
do.
again. Okay, can you see it now?
Yes.
It's clear.
Perfect. So I will go back to the slide. So then, when they start to understand that different aspects of the patient assessment might be related to a health condition, they start to project what they need to do under this health condition that they detected on this patient. So they start to project the future interventions that they need to do to improve the actual condition of this patient. And when we do this cycle from perception to comprehension to projection, we are implementing on them metacognition processes. We are making them aware about the way they think. And this is very complex to say, but metacognition is this, is to bring them the knowledge that everything we do, we can think before doing it. And if we think about the things that we are thinking, this will give us more security in the way to make a decision and to take a decision. So we need to make them learn that these three steps from perception to comprehension to projection is very important for the learning process, and we need to assess in each point, in which point are our students, to make sure that we can improve and give the right tools for them to progress on this learning path. And this is very interesting because sometimes our students have this vision. They have a problem, they see a solution, they see their solution, but they don't know that probably for the same problem, there's different solutions. And this is the perception. They only see a problem and they go straight for the solution that they know that will cover this problem. But we as educators, we need to tell them that there's more solutions for the same problem that they detected. And with this, we need to teach them that this solution that they selected might have a result that might be positive, might be negative, but not always the solution will give us the result that we are expecting, even if it's the right solution. Patients interact and have different outcomes when we treat them. And when we need to start to generate on their minds is this complex system, which from one problem there's a potential good solution that probably needs to be combined with other that has a result that implies the need to go back and apply another solution combined with the other to make sure that we can reach the outcome that we want. So we need to make them know that the care process, it's very complex, and we need to do this escalation of our learning path to make sure that this vision of perception, comprehension, and projection is achieved during the undergraduation process. And this is the real thing. It's very different from training with the arm placing an IV when we have a patient with a clinical context, with family behind, when we have working colleagues on our side, and we need to interact and take decisions as it would be in the real world. So this is what clinical simulation tends to do. We need to transfer, and we need
Hello, we are unable to hear.
Hello, Pedro. Let us wait for a few minutes, maybe due to network issues.
Sorry, I'm not sure if it was my connection.
Yes, yes, yes. You can reshare
It
your
was my
slide.
connection.
Yeah.
Sorry, I do apologize. So this is the final parameter that we need to know and be aware of. We have the know, we have the know-how, where the skill training can be inside of this process. We need to show them about how can they apply and do this kind of skills, technical and social cognitive skills, in a safe environment, which can be done with a simulation methodology to train them and make them capable to be more safe and secure on the clinical site when they do their training in the hospitals or other clinical fields. And this is one of the important points which in Excel give us some standards about how can we use and how can we assess all this process. Oh, sorry, because I think this is not okay now. So in Excel, give us a specific information about the evaluation of learning and performance. How can we do it, and how can we implement it in different phases? So first of all, we need to understand that assessing with simulation is a possibility, but we can only assess when we had the possibility to define and to implement all the paths that we explored before. We can do and we can use simulation for formative evaluation, for summative evaluation, or also for high stakes evaluation. But what INEXEL says to us is that when we want to apply simulation as an assessment methodology, first of all, we need to make sure that the assessment must be aligned with the objectives and the design. So I cannot assess something that I didn't have the possibility to train before with my students, because this wouldn't be fair. Sometimes I can do that when I want to have a formative overview about their knowledge level before starting the learning process. But when it's not formative and it counts for their learning, and it's summative and it counts for their learning objectives, it's important that we already had the possibility to train the objectives that we are assessing, and also that they already had the possibility to use simulation to train these objectives. We need also to use valid, reliable, and appropriate assessments methods. It's not all about someone's perspective about what the student is doing. It's important that we have sometimes tools or a score system that we can use to make sure that we are being impartial in the way that we are assessing, and also that we are not leaving anything important for the assessment process, and also the way that we can give feedback to them. And then this is linked with the fourth path, the fourth point, which is we can not only assess and give a note, give a score, we need to also debrief and give feedback about what they're doing. We need to debrief and give feedback about the simulation, the simulation handicaps that we observed, but also the things that we consider that they've done in the right way, and we need to reinforce what they're doing, because probably they're not conscious about their gained abilities. So we need to reinforce that. And we can only do this through the briefing and feedback, because giving a score, sometimes it's not enough. And for that, we need to have faculty that are trained to use simulation as an assessment tool. because accessing with simulation, it's cognitively, it's more intense and requires more abilities. And it's very important that people and faculty that use simulation to assess are trained to do it. We need to also ensure that we do it in the standardized and fairness way. We apply confidentially as well when we are working with this, when we are applying simulation as an assessment strategy, and we need to make sure that we apply the same strategy for every single student that are under the same conditions. Include evaluation of the simulation itself. It's important that the students can access always the way that they've been evaluating, because probably we will find some improvement points about this process. And the other point is that we need to ensure methodological alignment between learning and assessment. We need to expose. So it's very important to, once again, make them comfortable about the way they are being evaluated. And sometimes it's very aggressive if we've been doing theoretical, practical exercises with them, and then we go straight to evaluate with simulation when they were never exposed to simulation scenarios. So sometimes it's very important that we can access using a similar methodology or a similar tool or a strategy that we used before during the learning process. And that will be all for this seminar. I've reserved a few minutes for your questions, for your considerations, and I'm more than welcome to keep in touch with you. That's my personal information that you can contact, my LinkedIn and my emails addresses if you would like to be in touch. And also, if someday you pass through Barcelona, please feel more than welcome to tell me, and I'm more than welcome to show you around my hospital and my university simulation lab. So please don't hesitate, and the floor is yours. So please don't hesitate to open the mic or write in the chat, and I'll be more than glad to share some information and answer your questions.
Thank you so much, Mr. Pedro, for that insightful and engaging session. So we will now open the floor for questions. I request all the participants to kindly pose their questions, or you can unmute yourself and you can ask your questions to Mr. Pedro.
Hi, Pedro. This is Robert here. Just wanted to know, like, do you have any reference guidelines for the simulation initiations? Suppose if I wanted to implement on a simulation um, at my healthcare facility, which is the best reference or guidelines that I can refer for implementation?
Me, the more comprehensive ones at this moment, and that covers a range of characteristics that we need to be aware of when we start this simulation process as facilitators, as learners as well. For me, is in Excel. In Excel is the one where you can discover the different best practices guidelines for the different points of development that you will face during your facilitator learning development. And this can be applied not only for yourself as a facilitator, but also for your team, for your organization. So, and and this is the main goal of and the main the most interesting thing I would say about the in Excel guideline standards, because it gives us this situational awareness about what everyone should know, what everyone should do, and what's the evidence based behind the actions that these guidelines recommend us. So for me, it's the most comprehensive ones because they are based on evidence. They are a consensus between different experience and different experts internationally, and it makes us capable to know that from India to Australia to Spain to America, we are using and applying simulation as a methodology in the same way. And for me, this is very important, and I would definitely recommend in Excel guidelines.
Thank you.
Anybody else would like to ask question related to the topic? If you all want to become, who are not the member of the INAXIL, you can become through us also. You can reach out to us. We will help you out to become the member of the INAXIL, because we are already the North India Regional Interest Group, and we will help you out to enroll into this, and you can easily download all their guidelines, the standards, and you can get all the updates related to the INAXIL, what are their projects and what all the things which they are coming up to. You can message in the WhatsApp in our group also. We will help you out. Any other questions related to today's topic? So Pedro, I would like to ask one question. How can institutions with the limited resources effectively implement simulation-based assessment while maintaining the quality and standards? As in the last, it was suggested that according to the INAXIL standards, it should be aligned with the standards. So how, with the less resources also, we can implement the simulation-based training and maintaining the standards also? Pedro, you're muted.
Sorry, I do apologize. So this is a very interesting question, Robia, because it's something that I've been thinking for a long time, and it's something that I learned from the INAXIL best practice standards, and also through the Simulation International Consensus, which is sometimes we have in our heads about high fidelity simulation, and simulation is much more than that. Simulation is about generating high impact with low resources. In terms of, we don't need expensive materials, we don't need very complicated scenarios to say that we are doing simulation. Because simulation, when we apply the different guidelines and we apply the standards, sometimes with low resources, we can have high impact interventions that will definitely impact not only the students, but directly the patients and their families. And this is something that we can learn. If we review the guidelines and the best practice standards of INAXIL, you can see that nothing is expensive, because it's all about methodology. It's all about being systematic the way you do things. It's the same of the learning process. Sometimes we don't need to have an expensive mannequin to make sure that we can meet the learning objectives that we propose for this scenario. Sometimes the same scenario can use different strategies and resources, and we will reach the same outcome in terms of our learning process. What we need to use is a fundamental tool, which is creativity. Creativity is very important for us as faculty, as educators, to make sure that sometimes it's not about a very expensive mannequin. We can do much more with less. And that I learned from, sometimes to myself, I cut my resources. Even if I have them, I cut them, because I need to gain this creativity about how can I transform the way I see the scenario to something that is less complex, but very high impact in terms of education outcomes.
Thank you so much. There is one more question in the chat box. How do you ensure psychological safety while evaluating during simulation? Can you give any example of what you have personally done?
Psychological safety is something very important and very complex to achieve. And I would say that psychological safety is not something that we just implement in seconds. It's something that we build. And this safety is interaction, a continuous interaction between us as faculty and the students. And small actions that we have, we can increase this self and the self psychological safety and the group psychological safety. But there's small strategies that can be improved and can give to them the possibility to feel that they are in a safe space. One that I think it's very important is to be transparent and to always say that we are working in an environment that the main objective is to, first of all, learn from the mistakes, that every mistake is a learning opportunity, that we have a human condition which we will do mistakes, but simulation, it's not all about the mistakes and the errors. It's about how do we work together as healthcare professionals or future healthcare professionals, and the way that everyone in that room is competent and is doing their best to become a better healthcare professional or a better student. So they need to feel that they are not failing in any moment, they are learning with the things that probably doesn't go on the right way or the way that they expected. And this is very important for them because this will help them not only to build psychological safety during simulation, but also to transfer it to the clinical side. Because in the clinical field, not all clinical cases will go in the way that we expect. So the clinical safe container that we say, it's a very broad concept, and small things can actually be very impactful for our students.
Thank you. I hope Sheila ma'am has got her answer. The next question from Ms. Suman Franklin, that is, what are the best methods to assess clinical competency through simulation?
Mm-hmm. There's many ways, and it depends about what we are assessing. For example, the most basic thing is about a checklist. One of the things that I like to use is inverted assessment process, where the students can also assess themselves and the others about their doing. When we're talking about abilities and low complex simulation scenarios, we call it the paint-in process. So the paint-in process is where they see a step-by-step process, they have a checklist about this step-by-step process, and then they can do the step-by-step process. Other colleagues can check about this step-by-step. The colleagues give to them feedback about what they've done, and also the person that have been doing the procedure, they can give their perspective and their feedback about how they've done it. So this construct of repeating the cycle between students is also an assessment process, because we can see the improvement and we can also make them responsible for their own assessment between colleagues, between the peers, or to themselves. So it's just one example of many. There's score scales, there's other strategies that you can develop depending on the strategies you are evaluating or assessing. So there's different processes to achieve and to define the way that we would like to assess and the materials and tools we're using.
Thank you very much.
Okay, the next question is this: how do we manage large students group during the simulation assessment?
This is very important and very complex, because sometimes we have many students. So it's important to know how many students we have and how many faculty are available to access. And some of the most basic process that we have is the station process, which we divide this group into small groups or into pairs, couples or groups of 3 or 4, and then we give to them clinical scenarios that they need to do interventions according to the learning objectives that we propose and the assessment that we have. So sometimes it's better to split groups into small groups, and this is one strategy. There's many more. So then we can make sure that we give a more personalized assessment process, and also the students have a more safe and secure environment to show and demonstrate their skills.
There are many more questions. I think the questions now which is coming up is related to the second session, because this is just the foundation of the simulation-based assessment. But nevertheless, I will ask this question also. How do we validate train the trainer program?
There's many ways that we can validate. We can validate internally or externally. So when we think about a program, we can have external societies, or in this case, we can have organizations that they can access our program and have an idea about how we build, how we developed, implemented, and access this trainers. And then we can give an evaluation, and we can have a validation process through there's a specific name that I forgot right now, accreditation process of the trainer program. Or we can do internally, where we can validate to ourselves and see the progress of what we're doing, the progress of the past trainers and the future ones. How do we mitigate the opportunities to improve, and how we've been improving, and what's the outputs from this program. There's nationally and internationally societies and organizations that do accreditation, and this is very important because it gives you the security, not only that your program is quality, is in a high standard of quality, because quality insurance nowadays it's very important, but also gives you the possibility of improvement to make sure that you are aligned with international standards and you are giving the best and the updated learning opportunities to your faculties.
Thank you so much. Thank you so much, Pedro, for once again for sharing your valuable insights and expertise with us.
You're welcome.
So today's session has provided a strong foundation for understanding how simulation can be effectively used for assessing the clinical competence. I would also like to thank all the participants for their active presence and engagement. We look forward to seeing you in our upcoming session, which is more in detail about the assessment that is, once again, I would like to reflect into this, that is designed to decide. In that, you will understand that how you can prepare the OSCE and scenario-driven simulation-based assessment. And in session 3, as per your question itself, standardized to sustain. In that, you will understand about the validity, reliability, and the documentation of the assessment process. So thank you so much, everyone. And I request everyone to be engaged in the other 2 sessions to get your certificates as well. So it is mandatory to attend all the 3 sessions. Thank you once again, Mr. Pedro, for giving us such an insightful session.
Thank you so much, Pedro.
Thank you very much.
Thank you so much.
Thank you so much for the
Pedro.
opportunity.
Thank you.
It's always a
It was
pleasure.
good. Yeah.
Thank you so much, Pedro.
Thank you. Thank you.
Thank you for the insightful sessions.
You're welcome, Robert. Thank you very much. It's a pleasure.